Good afternoon. I would be discussing on unmet needs in exon 20 EGFR insertion mutation. It is less discussed and less studied than the common mutations which we generally see in EGFR. So NSCLC, as we all know, is not one disease. Molecular subtyping is very important, and EGFR mutations are amongst the most prevalent actionable driver mutation. All EGFR mutations also are not same. Oncogenic mutations generally occur from exon 18 to 21, and exon 20 insertion mutation is third most common mutation after the conventional or common exon 19 and exon 21 L858R. So knowing about it is important. This is the structure of exon 20, EGFR exon 20. You have an extracellular domain, then a transmembrane domain, then exon 18, 19, and then 20. It is the tyrosine kinase domain. If you see exon 20, you have a C helix initially from 761 to 766 codon, and then from you have a loop. It is also divided into near loop and far loop, and you see a lot of insertion mutations in the loop. So in-frame insertions in exon 20 of EGFR are seen in up to 12% of EGFR mutated patients. So if in absolute number we see EGFR exon 20 insertion mutation is probably somewhere close to ALK mutation or ROS mutation. So it is equally important and probably less studied. So as discussed, you have a helical region, near loop and far loop. The most common mutations occur between 761 to 775. And generally it is either duplication or insertion mutation. You have some other exon 20 mutations, T790M, which we all are aware of. It is a resistant mutation, it is not an insertion, and it is different. The way it acts is different than what we see in exon 20 insertion mutation. And other uncommon exon 20 mutation is S7681. It is an activating EGFR mutation, and we see some conventional EGFR TKI working in this mutation. So what we are talking about is exon 20 insertion mutation and not the other two exon 20 mutations. So again, in exon 20 insertion mutation, there are multiple unique variants, more than 100, which was seen in this retrospective study, and of which 767 and 768 mutations are more common. So generally in our practice, we see that platinum doublet with or without immunotherapy is first line treatment in exon 20 insertion mutation. Still we don't have approval for amivantamab from DCGI in first line, though we have data for amivantamab in first line now. And the median overall survival which we expect with platinum doublet and immunotherapy is somewhere between 6 to 28 months. Because this is a retrospective data, you have a huge range. But in real world practice, we know that generally these patients don't do well, even compared to non-driver mutation positive patients, because even immunotherapy is not working very well in this subset of patient. So median PFS is around 3 to 7 months, and for chemotherapy based regimen, and around 2 to 6 months for TKI. Initially we had TKIs, poziotinib and mobocertinib. Unfortunately both of them are withdrawn now, which used to work in this kind of mutation, and now probably amivantamab is the only drug which is approved. So this is same real world PFS in first line is 6.6 months and overall survival is 17.4 months. This is with platinum based doublet. And if you give IO alone, probably IO alone is not the way to treat these patients, even if whatever PDL1 is there, because with IO alone the median PFS is 3 months only. So in the first scan, most of the time you will see a progression. If you have given platinum doublet, what would be the second line treatment options? So now the natural would be amivantamab, but initially if immunotherapy was used or other TKIs were used, the median progression free survival was not more than 3 or 4 months. Even with TKIs, you see response rate somewhere between 0 to 20% or 17 to 42%. So, except platinum-based therapy or IO alone, we have already discussed, even in second line, they don't fare well. And so, largely, except amivantamab, we don't have great drugs to target these patients. Osimertinib, we had some data for exon 20 insertion mutation, but again, the median PFS was somewhere around 3.5 months. So, even osimertinib has limited activity in these patients. Mobocertinib, initially, we used to believe that based on far loop, near loop, we can decide whether TKI will work or not work and decide whether to give amivantamab or mobocertinib. Those who have used mobocertinib in compassionate access would have seen the toxicity. It is not an easy drug to handle. And eventually, with longer follow-up, the efficacy was not superior to chemotherapy, and hence the accelerated approval which was given by US FDA, the company has withdrawn the further progress of the drug. So mobocertinib is now not available. IO monotherapy is not recommended, as we discussed prior, because the PFS is really low. So initially the guidelines was you give platinum doublet first, and on progression you consider giving amivantamab. Now we have data, we are still awaiting DCGI recommendation, but amivantamab plus chemotherapy, platinum doublet with pemetrexed is generally recommended in first line, and on progression you give the next line of treatment. Real world data, we all are aware that compared to conventional EGFR patients, patients with exon 20 insertion mutation do worse. So this is real world overall survival, the common EGFR mutation versus EGFR exon 20 insertion mutation. 25.5 versus 16.2 months, and PFS 10.5 versus 2.9 months. 5-year survival rate again 8%. So these patients have poorer prognosis, they benefit less from TKI. Platinum based therapy is most commonly used regimen, and there is need of more effective treatment, which probably will be discussed in next panel. Again, some important points while we practice, if we do PCR, a lot of EGFR exon 20 insertion mutation would be missed. We have seen when we have transited from doing PCR to hotspot panels to now broad panel NGS, we pick more exon 20 insertion mutation, and this is true for other mutations also, not only EGFR exon 20 insertion mutations. Again, if you combine solid plus liquid, chances of picking up actionable mutation increases. So when feasible, that is also a good way to do a combined test rather than solid alone or liquid alone. So in PCR, if you pick around 5% of the patients, you pick 70% of the patients by doing NGS of the patients who are positive for exon 20 insertion mutation. So this is data from retrospective database, US based database, where PCR missed around 50% of the patients in both the Gini database and FMI database. So the message should be that broad panel NGS should be a better way to pick up exon 20 insertion mutation compared to the PCR. So these are various studies from India where the prevalence rate of exon 20 insertion mutation is ranging from 1% to around 6, the highest is 8.8%. So again, based on time, this study would have some PCR based study and some NGS based study. Most of them are NGS based now. So even in our country, we see around 1 to 8% prevalence of exon 20 insertion mutation, which in absolute form is an important number. Do we have any Indian data for exon 20 insertion patients? So we have two data. One is by Dr. Shruti and one by Vanita madam. Both are retrospective study. So one has shown median progression free survival of 6 months and overall survival of 15.8 months. And the second study has shown median overall survival of 5 months. I think that was a second line study. So there is unmet need surrounding exon 20 insertion mutation starting from first line and even in second line. the TKIs are not working, platinum doublet is not working, immunotherapy is not working. So we needed better options, and now we have at least an option to offer to our patients. I think that part will be covered in the next panel. I think this is the last slide. Thank you.